Hello everyone, I'm Dr. Neil Rathor and I'm doing my post-graduation in internal medicine. And the purpose of making this video is to just deliver the information in a digestible way, as it can be really mind-boggling to read things straight from a book. Basically, so to simplify it. Syndrome. So what is APS? And why do we read APS? So according to the book, APS is an autoantibody mediated acquired thrombophilia characterized by recurrent arterial and venous thrombosis and or pregnancy morbidity. So if we simplify this, APS उन पेशेंट्स में देखेंगे हम जब हमने सारे दूसरे डिसऑर्डर्स रूल आउट कर दिया हैं जिनसे थ्रोम्बोसिस हो सकता है एंड देन इफ़ इट फुलफिल्स द क्राइटेरिया तो हम सोचेंगे कि पेशेंट को APS है. So what are the major antibodies which are associated with APS? First one is antibodies against cardiolipin. Second is antibodies against beta-2 glycoprotein. And the third one is lupus anticoagulant. So these are the three important antibodies which are associated when we have to diagnose antiphospholipid syndrome. And how can we detect them in the body? So antibodies against cardiolipin and antibodies against beta-2 glycoprotein can be detected by ELISA. And lupus anticoagulant, since it affects the prothrombin time, it can be detected by APTT, KCT and DRVVT. So DRVVT is dilute Russell Viper venom test. These are the important assays by which we can detect the antibodies. And mainly, what are the phospholipids and why are the antibodies forming against these phospholipids? So phospholipids are found, they are the components of the cytoplasmic membrane of the living cell, and there are three important types of phospholipids. First one would be cardiolipin, जिसके against antibody बन जाती है anticardiolipin. Second is phosphocholine and the third one is phosphatidylserine. So these are the three important phospholipids जिनके against antibody बनती है and patient presents to us with thrombosis. So next up, we'll be looking at the important manifestations that how a patient comes to us when a patient has APS. सबसे ज़्यादा कॉमन है वीनस मैनिफेस्टेशंस, वीनस थ्रोम्बोसिस. व्हेन अ पेशेंट हैज़ वीनस थ्रोम्बोसिस जिसके मैनिफेस्टेशंस ज़्यादा कॉमन है एज़ कम्पेयर टू आर्टीरियल. So the first one is DVT, deep vein thrombosis. Patient can present to us with DVT. Livedo reticularis. So livedo reticularis क्या है? It is basically like a purplish discoloration हो जाता है और reticular net like pattern बन जाता है in the lower limbs, जो कि livedo reticularis बोला जाता है. Third is pulmonary embolism and there could be superficial thrombophlebitis. Now we'll be looking at the arterial thrombosis और उसके consequences क्या है. Patient may have stroke, patient may have cardiac wall thickening, patient may have Libman-Sick vegetations. There could be transient ischemic attack. Patient can be presented to us with myocardial infarction and coronary bypass graft thrombosis. Next up is leg ulcers or digital gangrene. So these are the important arterial manifestations. Arterial thrombosis in extremities. Now we'll be looking at the neurological manifestations of a patient of APS, in a patient of APS. So the etiology is a bit uncertain, but patient might have migraine, epilepsy, chorea, cerebellar ataxia or transverse myelopathy. It is not traumatic, it is transverse. Patient can also present to us with involvement of renal artery, renal vein. There could be involvement of kidneys, glomerular thrombosis. Patient may also have musculocutaneous manifestations like arthralgia and arthritis. But it is very important to see, it is very important to notice that the patient might have APS in patients with obstetric manifestations. So if a patient has preeclampsia, eclampsia, and fetal manifestations are very, very important. If there is early fetal loss in less than 10th week of gestation, if there is late fetal loss more than 10th week of gestation, or if there is premature birth among the live births. We'll be later discussing the criteria in detail. There are some hematological manifestations like patient may have thrombocytopenia and hemolytic anemia. Now, when it comes to diagnosis, it is very important to diagnose APS correctly, because when we want to diagnose APS, दो criteria fulfill होने चाहिए. एक clinical criteria fulfill होना ज़रूरी है और एक lab criteria fulfill होना ज़रूरी है. And in absence of any other thrombophilic causes, it is very important to rule out all other thrombophilia causes, because then only we can finalize that the patient have APS. So first up, we'll discussing the clinical criteria. In clinical criteria, one would be the vascular thrombosis. So what is vascular thrombosis? And it is defined as one or more than one clinical episodes of arterial or venous or small vessel thrombosis in any tissue or organ. So it is very simple. हमें देखना है कि पेशेंट को एक या उससे ज़्यादा एपिसोड्स हुआ है, ऊपर जो भी मैनिफेस्टेशंस हमने डिस्कस किए उनमें से किसी भी टिश्यू या ऑर्गन में. सो दैट विल फुलफिल द वैस्कुलर थ्रोम्बोसिस क्राइटेरिया. Next up would be pregnancy morbidity. So this is very, very important and it is usually asked in the exams. So what are the criteria which fulfill the pregnancy morbidity? So first would be one or more unexplained death of a morphological normal fetus at or beyond 10th week of gestation, meaning the fetus was okay till 10th week of gestation, and now there is an abortion after 10th week, spontaneous abortion. The next step would be one or more premature birth of a morphological normal neonate before 34th week of gestation because of eclampsia, severe preeclampsia or placental insufficiency. सिंप्लीफाइंग दिस, अगर कोई पेशेंट का प्रीमेच्योर बर्थ हो रहा है, जो फीटस टिल 34 वीक तक ही द फीटस वाज एब्सोल्युटली फाइन, बट देन द पेशेंट हैड अ प्रीमेच्योर बर्थ ड्यू टू eclampsia, preeclampsia or placental insufficiency. The third criteria is that 3 or more than 3 unexplained consecutive spontaneous abortions before 10th week of gestation. So before 10th week of gestation, patient is having 3 or more than 3 consecutive abortions, spontaneous abortions. So three important values to be remembered is less than 10th week, 10th week of gestation, more than 10th week of gestation, and 34th week of gestation. Next up is the lab criteria. What is the lab criteria? Again, the 3 antibodies which we discussed: lupus anticoagulant, anticardiolipin, or anti-beta-2 glycoprotein 1. If they are positive at intermediate or high titers, and they should be done 12 weeks apart. So that will fulfill the lab criteria. Last but not the least, we will be discussing the treatment of APS. So if a patient has first thrombotic event, we need to start vitamin K antagonist. And in case of any unprovoked venous thrombosis, we'll target the INR between 2 to 3. Next up is when patient has arterial thrombosis, we'll try and give low dose aspirin, 75 to 100 milligram every day. Very important that in pregnancy with a history of obstetric APS, we'll give patient low dose aspirin plus prophylactic dose of low molecular weight heparin. And if the patient still has recurrent obstetric complications, we will increase the dose of low molecular weight heparin from prophylactic to therapeutic, or we can give patient hydroxychloroquine 400 milligram per day, or we can give IV immunoglobulins 400 milligram per kg for 5 days. To sum it up, one GLAB criteria should be met, one clinical criteria should be met, and the diagnosis is there. A big thank you for watching this.